Welcome back to Open Med School. The last time we have discussed about the classification of hypertension. Today I'll be discussing internal medicine competency 8.2 and 8.3, the pathophysiology and genetic basis of hypertension. As we know, hypertension is one of the most important modifiable risk factors for cardiovascular disease. It affects approximately 30% of adults worldwide. 90% is essential and 10% is secondary, that is identifiable cause is there. So let us look into the basic principles of arterial BP. Arterial BP is equal to cardiac output into systemic vascular resistance, that is cardiac output multiplied by systemic vascular resistance. So hypertension occurs when the cardiac output increases or systemic vascular resistance increases, or both. So this is the basic pathophysiology. What are the pathophysiological mechanisms? First and foremost is renin, angiotensin, aldosterone system or RAS activation. Renin leads on to increase in the angiotensin 2 production, that leads on to vasoconstriction, and aldosterone is produced, that sodium and water retention occurs. So result is increase in the blood volume due to the aldosterone action, and the peripheral vascular resistance increase due to the angiotensin. So this is one of the key therapeutic targets. Second is sympathetic nervous system. Increased catecholamines produce increase in heart rate, increased cardiac output, vasoconstriction. So this may be a contribution in stress, people with obesity, sleep apnea, and chronic activation leads on to sustained hypertension. Third mechanism is renal, that is volume-overload theory. Kidney fails to excrete sodium, that leads on to volume expansion, leads to increase in cardiac output initially, and later systemic vascular resistance increases. Pressure natriuresis curve is shifted, that is there is a sodium retention is occurring. Then the fourth factor is endothelial dysfunction. Decrease in the nitric oxide, which is a vasodilator. This endothelin is increased. Endothelin produces vasoconstriction. Net effect is increase in vascular tone and vascular remodeling. And finally, the next is vascular remodeling that is occurring. In chronic hypertension, the arterial wall gets thickened, then lumen becomes narrow, and that produces increase in the resistance. So it becomes a self-perpetuating cycle. So we have discussed now what is the underlying mechanisms for high blood pressure. That's one is cardiac output, second is peripheral vascular resistance. These are influenced by the one renin angiotensin aldosterone system, second is sympathetic nervous system, third is the renal problems, fourth is the endothelial dysfunction. These are some basic things that produces changes in the cardiac output and peripheral vascular resistance. Now we go into the pathophysiology of secondary hypertension. We have mentioned that 90% or 95% of hypertension is essential, and there is no single etiology is there. But when there is single etiology, such hypertension is called the secondary hypertension. Among the secondary, the most important cause is renal parenchymal disease, the most common. It produces sodium retention, volume overload, RAS activation. Example, chronic kidney disease, any glomerulonephritis. Second important cause is endocrine cause, primary hyperaldosteronism. This leads on to sodium retention and hypokalemia, hypertension with hypokalemia. Even while on diuretics, always think about the possibility of a primary hyperaldosteronism. Second is Cushing syndrome. Increased cortisol, that leads on to volume expansion, that is pheochromocytoma. Increased catecholamines, that produces increase in cardiac output plus systemic vascular resistance. Then comes the renovascular hypertension. Classical example is the renal artery stenosis. This produces a decrease in the renal perfusion. This leads on to increased renin angiotensin. Secondary hyperaldosteronism. So angiotensin leads on to production of aldosterone from the zona glomerulosa. Then vascular causes, think about coarctation of aorta. So that leads on to increases systemic vascular resistance. Classical finding is the radiofemoral delay. Other causes are obstructive sleep apnea, sympathetic activation occurring in Second, drugs like NSAIDs, steroids, oral contraceptives. This again leads on to increase in the volume and the hormonal effects can lead on to. So, what are the clinical clues to secondary hypertension? One is hypertension not responding to routine medicines, that is resistant hypertension to drugs including. Third, onset before the age of 30 years or very late, early age, late age. Sudden worsening, severe hypertension, that is BP more than 180, 110, etc. and hypokalemia. Now we go on to IM 8.3, genetic basis of hypertension in the next session.